Okay, so DAT and IAT procedures. We've done the IAT already, modified IAT, and that was with your week D, right? So we're just going to talk about the two procedures themselves. And we're going to do this in lab today on your blood. Okay, so just to go over what reagents you have in your little box. The green reagent is your anti-human globulin. And remember, it forms that antibody bridge to make agglutination. So you added AHG when in your procedure? Do you remember? With the week D, at what point in the procedure did you add it? At the very beginning?
After washing.
After you incubated it, and then you washed, and then you added your AHG, right? Correct. Okay. So anti-human globulin is simply, they take human IgG and they inject it into a bunny rabbit, and then it makes antibody against the human IgG. Okay. Then they turn the bunny around, that tickles me every time, and inject human complement, and then the bunny makes anti-human complement. Okay. If you take the anti-IgG and combine it with the anti-C, you get a polyspecific, which means you have both of them in one bottle. So remember when we looked at the bottles and I told you, you might have just IgG or you might have polyspecific. Just depends upon whatever gets donated to me and whatever the most I have, okay? Again, we don't worry about complement because what kind of specimen do I give you? What did you draw today? EDTA, right? So hopefully we don't have to worry about complement. Okay. Other reagents that we've used so far, AHG control, or your check cells, your Coombs control cells. They are IgG sensitized red blood cells. So they are red blood cells with IgG antibody already bound to them. Okay? And they are O positive cells coated with anti-D. So again, think of a O cell, right, from the ABO, O blood group, that has D antigen on it, and they have given it D antibody to bind to the red cell. Make sense? So you have the red cell with antibody already on it, okay? So technically, we could make our own check cells if we wanted to, but that's all they are, O positive cells coated with anti-D. So your check cells confirm proper cell washing. Again, we want that dry cell button at the end, okay? Checks and make sure your reagents are good and that you added them, right? So your check cells should always give you a 2+ reaction. Now, I know for whatever reason they sent us weak check cells. We didn't order weak, but they sent us weak. So we're not getting very good strong reactions. And I noticed on your quiz that some of you put negative. Because you always want them to agglutinate, I want you to get in the practice of expecting a positive reaction. So even if you don't get a positive reaction in your check cells, please tell me that it would be a 2+. So I corrected it on your quiz. I did not take points off for that, okay? But because we aren't getting any agglutination just in this lab itself, do not go to your clinical site. No, but Barb said. But just in this lab, let's go just a hair longer on our check cells. So just maybe 40, 45 seconds, and let's see if we can get some positive reactions, okay? Again, just in my lab, let's just see if we can do that. If your check cells do not agglutinate, you technically have to repeat the entire procedure over again. It means your test is invalid, okay? We don't have time for that. They only give us a couple hours per lab. They don't give us all day. So I'm not going to make you do that. That's why I want you to put 2+, even though you don't get it, just because I want you to get in the habit of knowing that you have to have a positive reaction, okay? So again, you'd have to repeat it if it came back negative. So anti-IgG Again, your IgG's attached to your red cell, okay? Other reagents in your box. You have got antibody screen cells. We are going to use those today for the very first time. Screens 1, 2, and 3. They can either come as a set of 2 or they come as a set of 3. I have Jean order me 3. When you do this next week with Gretchen, because Gretchen starts today, she's going to start you on the gel system today. She's always going to be like 1 week behind me because you already know how to do the ABO and the tube typing. She's now going to show you ABO and the gel. Okay? The gel typing is not on your final practical, but at the very end we will incorporate it all into a lab. And when Jean's gone on her trip in February and I have you all day long, we make it a really big lab day and just kind of throw everything in there just kind of so you see everything. But I don't put it on your practical. So you have 3. And inside your box, you have a little piece of paper that is the antigram for those screen cells, okay? What your screen cells basically are, they are a matched set of 2 or 3 group O red blood cells bottled individually. So you have 3. And it's from, so screen cell number 1 is from 1 donor. Screen cell number 2 is from a 2nd donor. Screen cell 3 is from a 3rd donor. What they have done is they've taken that donor blood, they've taken their red blood cells, and they have antigen typed that for all those other blood groups that you guys are going to do on Wednesday. Okay? So they wanted to find out, does this person have Kel? Does this person have C? Do they have little c? Do they have D's? They antigen typed them for everything. Your antigram basically gives you the information. And on your antigram, so you'll look at it today, your antigram says D, C, E, Kel, the whole 9 yards, okay? And then if the D antigen is present on the cell, your antigram has plus, which means that cell has that antigen on the surface, okay? And if it does not, I think they give you an O, if I'm not mistaken, which is bad blood, thank you for that. Okay. All right. So it's a single donor. They've antigen typed that donor. So does it make sense that I don't want to use blood from 3 different people, pool it all together, and then use that? Because then, you know, think about all the antigens you've got, right? Then a 2nd donor. So if that's screen 1, then you have a 2nd donor in your 2nd bottle. And let's say that person has M, you know, N, maybe S, a P, okay? So the antigram for that patient, they don't have a D, so it would be negative, okay? They don't have a C, so it would be negative. But over here where you've got your P, right, now it would be positive on that screen cell, okay? 3rd one, same thing. So what's the idea? I'm going to take patient antibody, patient plasma, right? I'm going to add the patient plasma to screen cell 1, 2, and 3. If it agglutinates here, but doesn't agglutinate here, I can look at what does this person have that that person doesn't have, right? And I can eliminate it. Narrow down what antibody do I have. Because the antibodies, you can't see them, right? They aren't standing there with a picket sign saying I'm a D, right? We got to figure out what it is. So the screen cells. The screens are manufactured in such a way that it almost will eliminate just about every antigen. Almost, okay? If your screen comes up positive, what that means is you have an unexpected antibody in your patient plasma. Okay? We have to find out what that antibody is, because if I'm going to give them blood, do I want to give them blood from a donor that has that antigen? No, I do not. Okay? If your screen comes up negative, That tells us that your patient doesn't have an unexpected antibody from the pretty much popular antigens. But remember, I always told you there are some of those that are really weird that are out there. So if you start getting funky reactions, just realize there's something, that's really not common out there. But for the most part, if your screen is negative, your patient does not have an unexpected antibody. Okay? 98% of the time, you're going to have an ABO with no discrepancy. You're going to have an antibody screen. It's totally negative. You're going to put in your computer that my patient is APOS. My donor unit is APOS. My antibody screen is negative. And the computer will say, give that person that blood. 98% of the time. It's that other 2% that's going to cause you problems. Okay? So today, I had you draw blood on yourselves. I want you to do a type and screen, antibody screen. Type and screen on your own blood. Okay? For those of you who have recently had babies, we might see some unexpected antibodies. Okay? We don't know. We'll see. Be interesting to find out. Okay? So we'll see. But I expect that the rest of you, you've never had a blood transfusion? And I know you've never been pregnant, so I'm pretty sure you're going to be a negative. But anyway, anybody here had a blood transfusion? No? Okay. So if you haven't had a blood transfusion or pregnancy, probably you're negative. So each bottle has been typed for clinically significant antigens, and they are accompanied by an antigram. Again, antigram is that paper that's in your box, so never throw that away, because that tells you what antigens are on those red cells. Okay? Next week, we're going to start doing panels. If our antibody screen comes up positive, that tells us our patient has an unexpected antibody. We can rule it out using our screen cells, but we're not on 95% confident. Okay, so we need more cells to prove what it's got. So there are 8 to 16 group O red cells. Some are positive, some are negative, because we might be looking for a D, right? So some are D positive, some are D neg. But group O red cells that are bottled separately, which means bottle number 1 is patient number 1, bottle number 2 is patient number 2. They are not pooled blood. That would be a nightmare. Reactions with the antibody positive patient serum are compared with the antigram to make the identity of the suspected antibody obvious. We're going to learn how to cross out. When you go to Blackboard, underneath where my syllabus and the PowerPoints and all that stuff is, there's one that says videos. Okay, Diane linked all of the MLT videos, so there's chemistry, there's all of them are there. But when I looked it up, it was like in the first row that you could choose was, I think it's called Crossing Out. I think is what she titled it. Not exactly sure why, but Crossing Out. So sometime between now and next week, you need to watch that video. We're going to talk about the crossing out a little bit on Wednesday, but I can guarantee you I've never had a student get it the first time. And some take it 2 and 3 and 4. Last year we put the video up for the first time, and I can honestly say it was the quickest I'd ever seen students finally get it. So really watching the video will help you, okay? All right. So those are your panel cells. And we're going to do panels next week. Today we're just going to screen. Sorry. DAT specimen requirements. So if we're going to do a DAT, what you're, probably jumping the horse here. Whole blood, EDTA whole blood, so complement can't be activated. All right. You can also use some of the other ones. ACD, and CPD. Those are ones that are in units of blood. That's the anticoagulant that's actually in the unit when we draw a unit of blood. Okay? So it needs to be fresh, less than 24 hours old. If using a clotted specimen, keep the specimen at 37. False positives due to complement binding to the red cells. But again, an EDTA whole blood specimen, less than 24 hours old. The direct antiglobulin test. We're going to do this today. The DAT tells you, did antibody bind to the patient's red cells inside their body? Okay, they produced an antibody. against an antigen on their red cells, and it bound inside their body. So in vivo, red blood cell sensitization. So think about this. If you have a baby, right, and mom's D negative, baby's D positive, mom built an antibody, it crossed over to baby. That antibody coated those baby's red cells. So now you have baby red cells with antibody coated to it. Now what that's going to say to the baby's immune system is, I'm the enemy, right? And your baby's going to rupture their own red cells. They're going to become anemic, right? But we need to find out whether or not that has happened. So you wash the cells 3 times to remove any free globulin, any free antibodies. Cord blood, remember, because of the Wharton's jelly, you may need to do it. We can do baby cord blood up to 6 times, I'm sorry. 3 as a norm, up to 6 times if it's not still clearing. What do you do if you, after 6 cord blood washings, it's still giving you gooey reactions?
Heel stick.
Heel stick. That is on your final practical, so please remember that. So you're going to add 2 drops of AHG reagent. So you're going to wash your cells 3 times, and then immediately just add AHG. Nothing else. Wash cells, 2 drops of AHG. Centrifuge. Read and record the reaction. Okay? Now, most procedures will tell you that you have to do a room temp incubation. And my procedure in your syllabus does say a 5-minute room temp incubation. So you're going to wash your cells 3 times. You're going to add your AHG. You're going to centrifuge it. If it's negative, just set the tube in your rack for 5 minutes or so. And then just centrifuge again. Okay? And then if it's still negative, you can call it a true negative. If it is negative after the 5-minute incubation, you need to add check cells. Again, we're doing AHG, correct? So what did we do? We washed, then we added AHG. What do your check cells confirm? That your washing worked and that your AHG worked, right? Right? Okay, so that's why we're going to do check cells. To all negative tubes. If it becomes positive, we don't need to do it. So what does a DAT tell you? It's helpful in the diagnosis of hemolytic disease in newborn. Is mom sending antibody across the placenta and attaching to baby's red cells? Okay. It will help diagnose an autoimmune hemolytic anemia. So the patient's rupturing their red cells because their own body has built an autoantibody against their own antigen. The antibody has bound to their own red cells. What does that say to your immune system? Yes, ma'am?
Your DAT is going to be negative, right?
You want it to be negative. But if your DAT is positive, see DAT positive?
Sorry, yeah.
Okay.
Now after I asked.
Yeah. No, that's okay. Okay. So your DAT should be negative, but your DAT is positive. So it can be helpful when you're working up any of these. Again, diagnosis of HDN. Then you can tell the doctor, hey, this baby has a positive DAT. You need to watch it for anemia, right? And they're trying to break down that hemoglobin. They can become jaundice, and too much of that can cause brain damage, right? So you want to be careful. Diagnosis of an autoimmune hemolytic anemia. Autoimmune. They're building antibody against their own antigen. The antibody is binding to their red cells in their body. What does that say to their own immune system? I'm the enemy, right? Destroy me. So an autoimmune hemolytic anemia. They become anemic because their own body is rupturing the red cells. Investigation of red cell sensitization caused by drugs. There are certain drugs that prescription drugs, I don't know about over-the-street drugs, but prescription drugs that can actually cause you to build an antibody. They're very similar to the antigens on your red cells. Okay? So if we figure out that it's due to a drug, what are we going to do for that person? Change their medication, exactly right. And also an investigation of a transfusion reaction. Okay? Transfusion reaction. Big one for transfusion reaction. Did we give them the wrong antigen? Okay, the second procedure we did, again, we did a modified IAT when we did the week D. Today we're going to do the entire IAT, a little bit different. EDTA, if you're going to do gel testing, if you use a clotted specimen, you need to store it if it's not used immediately. But again, we're going to use EDTA. So the indirect antiglobulin test. Used to detect antibodies that may cause red blood cell sensitization in vitro, which means the patient's plasma has antibody. They're not attached to the red cell. So in a test tube, in vitro, right, in a test tube, we can find that antibody present in their plasma. Okay? And this is just an abbreviated procedure. It's much longer, much bigger than this. Serum or plasma is incubated with specific reagents, okay? Your screen cells 1, 2, and 3 could be your panel cells 1 through 20, whatever it is you're incubating it with, okay? And your DAT was with the anti-D, remember? Okay? Not your DAT, your weak D, sorry. Cells are washed 3 times with saline, so you can put them in the cell washer. AHG is added, and then check cells are added to all negative tubes. Your DAT, remember, you washed your red cells, you add your AHG, you spin and read. This one, you're going to add your plasma, going to incubate it at 37, then you're going to wash it, then you're going to add your AHG. That sounds similar to the week D that we did? Okay. I'm putting the cart before the horse. Okay. So why is the IAT useful? Again, for a positive. You want your IATs to be negative if you're doing an antibody screen or a panel, right? You want them to be negative. You're never going to do a panel if your screen is negative, but, okay. Detection and identification of unexpected antibodies. In that patient's plasma, they have an antibody to a blood group antigen. And if we give them a transfusion that has that antigen, that antibody is already present, what's going to happen to that donated blood? They're going to rupture it, and it's going to be hemolyzed, and then you're going to just kill their kidneys, right? You're giving a blood transfusion to save their life, but yet their body's just rupturing it anyway, and you're going to kill them anyway, okay? Cross-matching, compatibility testing. That's what we're getting you to. How can I give blood to a patient and not have a reaction? That's our goal, okay? Detection of red cell antigens not detected by other methods. Which means if I have a patient that's giving me funky results, I mean, it just, 1+ here, and I'm just like, why is this coming up? That can be useful in detecting. Again, there are some very rare things out there, okay? And again, that's going to happen to you at 2 o'clock in the morning and, when you problems. But it can help. An IAT can help. You just have to keep throwing different red cells at them, have different antigens to finally bind to that antibody. Sources of error in the DAT or the IAT. You can get a false negative. Okay, so it's really positive, but you're getting a negative result. Inadequate washing. Need that dry cell button. Under centrifugation. Timing delay in testing. Okay. Incorrect cell to serum ratio. What is your ratio? What have I been telling you from the very beginning? 2 to 5% on your cells, right? Yes. Not adding or a defective AHG. So what do your check cells do for you again?
Make sure all oxygen.
Exactly. Yes, ma'am.
So you've got under centrifugation. Can you over centrifugate it? I mean, I'm under centrifugate.
Okay, this is false negatives.
Okay.
False negative,
Okay.
which means it should have been positive, but you got a negative result.
And because you didn't centrifuge enough, it's washing some of the cells away.
Not washing them away, it just didn't break that zeta potential
Got it.
and get the cells together for agglutination, right? So some false positives, okay? Saline has bacterial contamination. And I'm proof positive that that works. Everything came up positive. Over centrifugation. Okay, now you're getting a positive when it's really a negative. Okay, over centrifugation. You did it too much. Dirty glassware. Makes sense. If you had junk in there, things will bind to it. It'll look like agglutination. And using specimens collected in SST. What's SST? That, did any of you have to take off a specimen and accidentally stick your transfer pipette in that gel by accident and that gooey stuff? Have you ever gotten it on your fingers? It's horrible. It's just sticky for days, okay? So again, would it not make sense that if I used a specimen with an SST and had that gel in there, I would get some false positive reactions? Okay, so we don't use SST. Okay, so today Gretchen's going to work with you with the gel. Have you ever seen, do you know what Plinko is? You ever watch The Price is Right? No? You ever go to Japan? Plinko is real popular there. So with Plinko, you have a board and there are pegs in different places on this board. And they're spread out in a pattern, okay? So with and then there's usually a dollar amount or something down here. So with Plinko, you take a chip and you drop your chip and it basically bounces between the pegs and falls to the bottom. And because it's bouncing off these pegs, you don't know where it's going to land. Okay? Sound familiar, Plinko? Okay. So the MTS gel system kind of has that principle. Inside the gel, it had little latex particles. And your red cells have to go between these latex particles. So you have like a little well, and in there you have all these little latex particles. And I'm making some bigger than others, and I don't mean to do that on purpose, okay? And you have your red cell, your one little red cell. Your one little red cell is going to go between those gel particles, and it's going to end up at the bottom. Okay? When you do your ABO, you have a 4+ reaction. What does that look like? Great big huge glob, right? Mm-hmm. So if your red cells are agglutinated and you have a really big glob, is it going to be able to Plinko between those particles? No. They're going to stay at the top. So if you stay at the top, it's a positive. If they all go to the bottom, it's a negative. Okay? Depending on the size of your agglutination. Don't we have 1+, 2+, 3+, 4+? Right? So, again, the bigger the agglutination, the less it can go through your gel. Right? So if all of them are single red cells and they can Plinko all the way through the gel really is about here. That's just a liquid, and that's your patient sample that you're starting with. Okay? So again, no agglutination, all your red cells were able to go all the way through all those little latex particles, and they all ended at the bottom, and you have a negative reaction. If you have a 1+ reaction, you have those little teeny aggregates, right? They can't really go down all the way, okay? So you have some at the bottom, but then you have some stuck in the gel. 2+ don't have very many at the bottom, more stuck in the gel out of the whole way, okay? 3+, bigger clumps, right? So some can go, but not as many. 4+ is that great big huge clump. Can it go through the gel at all? No. So you got it up here. What is an MF? Mixed field. Remember that person with that chimerism that has that one big clump but then has all those free cells? So a mixed field is you have, it looks like a big clump at the top, but yeah, you got cells going to the bottom with nothing in between. Mixed field reaction. Free cells with big clump. Okay? So that's your range of reactions. And Gretchen's going to do this with you today. If I remember right, you know in the tube system, you add your antisera first and then your red cells, correct? With the gel system, the antisera is already embedded in the gel. So the gel is literally blue or yellow, okay? And then you're gonna add the red cells to the top and then spin it through. Then if I'm not mistaken, when you do the antibody screen in the gel, which will be next week, I think you do it opposite. I think you put your red cells, and Gretchen will make it clear, I hope I'm not screwing you up, but I think you put your red cells in first and then your plasma on top, because when you centrifuge, you want the plasma to go through the red cells to bind. I may be wrong on that. I'm not the MTS expert, but I think it's different, but anyway. Okay, so you're gonna do that today. And today she's got the ABD gel, again, the blue, the yellow, the clear, and you're going to take your red blood cells, and you have to have a very light suspension. For tube typing, we need 2 to 5%. For the gel system, you need a 0.8%. So she's going to show you how to make that dilution, okay? And then, and she'll do that with you today. I hope, as long as she remembers to come today. So again, that's just more in your PowerPoint, and if you printed it small, you probably can't even read it. But that just gives you more of a description of what your reactions look like. Just another picture that they had. I don't know if she's going to give you a quiz or not. I'll leave that up to her. There's a written quiz. At the hospitals you work at now, do they have the MTS? Have you paid any attention?
Mm-hmm.
They have the MTS. So it's basically, if you were doing training at your clinical site, the training quiz that you have to take, we have that quiz. And so sometimes she gives it to you. It all depends on how much time she's got. There are some clinical sites that still just do tube typing, and there are some that use the gel. And the gel can get more automated. There are actually machines, ProView being one of them, that actually you have those cards and you just load it up and put it on the machine and push go. You know, it's kind of made it more automated. Okay, so it's good, it's good, it's good. All right, so what are some advantages you think of the gel system versus tube typing? It is faster. It is faster. Is there?
Room for error. because
Correct.
It comes already, the serum is already in the tubes.
Correct.
Can't mess with it.
Correct. And you have pretty clear-cut reactions, right? How many times have you guys shaken it off and go, well, Barb, what do you think? Is it a 1 or is it a 2? All right? Pretty clear-cut reaction. Plus, if you're in the lab at 2 o'clock in the morning and you're doing the screen on this patient and you're like, I don't know, are those tubes going to keep until the supervisor comes in the morning? No. But you can keep these gel cards. They don't really, we take Scotch tape and we put Scotch tape over the top, and they stay pretty good for about 24 hours. So you could hang on to it in case you had a question, and somebody else could take a look at it, save your reactions. Okay. As far as expense, how many little glass tubes are we using? Tube typing, a lot. How many transfer pipettes are we using?
At least 3.
A lot, right? Okay. So with the gel system, again, there's a cost factor. So they actually had us do, when they wanted to, the blood bank wanted to go to the gel system. The hospital wanted them to do a cost-effective analysis. Is it more cost-effective? So again, you're less tech time, right? Because you can kind of load it on the machine and push go. And then again, tubes versus transfer pipettes versus all those drop reagents and all that stuff. It's already in there. So at first, cost was about the same until she added in she forgot to add in something. I don't remember. Tubes or pipettes or something. And then it was like the gel was way better because of the expense. I don't remember exactly what it was, but so the gel does end up being a little less expensive. Yep. Any questions? Okay, so we're going to go to lab. And did everybody get blood? Do I have enough blood that everybody has at least one? Okay. You have a worksheet in your syllabus, and I'll find it in when we get in there. You're going to do a type and screen ABO, RH, and screen, 1, 2, and 3 cell screen on your blood. Okay? And you're also going to do a DAT on your blood. All right? And